First of all, let me begin by thanking Dr. Matthew John, Dr. Tituman, and the entire team of Providence Endocrinology who have very effectively organized this very brilliant cultural extravaganza. I'm extremely happy to be part of this. So my task here is to discuss on the association between hyperuricemia and diabetes mellitus. So I'll begin with a very typical case, 56-year-old gentleman who presented with a newly diagnosed type 2 diabetes mellitus. Came to the rheumatologist because he had a high uric acid. After evaluation from the diabetologist side, he was detected to have a high uric acid, and he wanted to know whether anything else needed to be done for that. He had no history of any gout or any other comorbidities by history. On investigation, his uric acid was 7.8 milligram per deciliter. So by definition, he met the criteria for hyperuricemia. Hyperuricemia is defined as a uric acid more than 7 milligram per deciliter in males and 6 milligram per deciliter in females. This is based on the saturation kinetics of uric acid at a pH of 7 at temperature 37 degrees. So beyond this concentration, uric acid can tend to crystallize. Hence, these cutoffs have been used. So at this point, what are the other investigations that needs to be done? For that, we need to know what are the associations of uric acid, what are the causes of hyperuricemia. So among the association of uric acid, the association with obesity, metabolic syndrome, diabetes mellitus, acute and chronic kidney disease, fatty liver, renal calculi, and hypertension are quite well known. But what is probably not so well known are these conditions which are associated with hyperuricemia. There are infinite number of conditions associated with hyperuricemia, but the ones which are important in clinical practice, or at least those cases we see on a not so irregular basis, are we occasionally have patients with psoriasis who present with hyperuricemia. We have picked up 5 to 6 patients with polycythemia vera who actually came with presented with just hyperuricemia. Hyperuricemia is a marker of congestive cardiac failure and renal dysfunction. So these would need to be to address too. And hyperuricemia can be a manifestation of hypothyroidism as well. Also, we need to be aware of what are the drugs which can cause hyperuricemia, because this patient may be on any of these drugs. So loop and thiazide diuretics, antituberculous treatment, low dose aspirin, cyclosporin, nicotinic acid, levodopa, testosterone. These are some of these drugs which have been very well known to be associated with hyperuricemia. So at this point, we need to really take a meticulous history. The history should address for any suggestion of hypertension, kidney disease, cardiovascular disease, obesity, renal stones. A typical history of gout should be asked for, presence of hypothyroidism. One should look for psoriasis, even if this is not very evident or the patient doesn't give history. Look for psoriasis in the hidden areas, such as the behind the ear or in the scalp, and also take a proper drug history to ensure that the patient is not on any drugs which increases uric acid. So based on this data that we have, we need to address the associated conditions. We need to look for causes which produces hyperuricemia. So I would like to do a complete hemogram. A high hemoglobin would be the only marker for a polycythemia, a renal function test, liver function test, thyroid, and possibly an ultrasound, because we know that hyperuricemia is associated with kidney stones and can be associated with fatty liver, as was spoken by my previous esteemed speaker. Now, after doing this, we'll be addressing the patient's query, and the first query that the patient is likely to put forward is, I'm having shoulder pain, is this gout? This is a very common complaint. Any pain in the body in the setting of hyperuricemia, patient tries to ascribe it to gout, and he wants to be started on some treatment to reduce uric acid. Now, what we need to know is that the typical gouty pain is very classical. It is monoarticular. It usually affects the lower limb alone, that is either knees or the first MTPs. It has a very acute onset and it lasts only a few days. Even if you don't treat it, it disappears in about 3-4 days, and the joint is often very red and hot like this. So the typical gouty pain is an acute onset pain, which is a typically lower limb predominant with extreme signs of inflammation. And even if you don't treat it, disappears in about 4 to 5 days. So in this patient who complains of shoulder pain in the setting of gout, in the setting of hyperuricemia, I would tell him that the gout is unlikely, and the shoulder pain is more likely due to adhesive capsulitis secondary to diabetes mellitus. Now, how to manage? So the next question that the patient is going to ask is, why am I having high uric acid? If the patient is a well-informed one, we can tell them that there is a decreased excretion of uric acid from his kidney. There is increased production. There could be increased production in his body. Some of the genetic factors may be important, and diet would be an important component of, cause for high uric acid. And the next question that patient can put us is this because of diabetes that I am having high uric acid? we have to remember 2 points here. The first point is that hyperinsulinemia itself increases uric acid reabsorption in kidneys. So high insulin levels, as is in type 2 diabetes itself, can cause high uric acid levels. Second point we need to know is that high uric acid can cause endothelial dysfunction and insulin resistance, and technically it can predispose to diabetes. So it is basically a chicken and egg scenario. Uric acid and hyperinsulinemia, cause or effect, we are still not very clear, but it can work out either ways. So the next question that I would expect is that patient would be asking, what risks am I having because of high uric acid? For that, I would like to draw your attention to this very wonderfully conducted study. This is a 3-year study from Japan, where they looked into, prospectively looked into the incidence of metabolic syndrome and other chronic cardiovascular diseases in patients who were previously normotensive, normouricic, normolipidemic, and they followed up these patients, normolipidemic, normotensive, and normoglycemic, and they prospectively followed up these patients for about 5 years. And what they found was that patients with high uric acid had an increased incidence of hypertension, diabetes, dyslipidemia, chronic kidney disease, and they were tended to become obese over a period of follow-up time. So yes, patients with high uric acid can have an increased risk for developing any of these complications. In addition, these patients also have an increased risk for developing gout. Now, what is the actual risk for developing gout? In a patient with a uric acid of more than 9 milligram per deciliter, there is a 22% lifetime risk of gout. In a patient with a uric acid between 7 to 7.9, the risk is about 2%, and in those with 8 to 8.9, the lifetime risk is about, the 5-year risk is about 4.1%. In addition to gout and other metabolic conditions that we described, renal stones are also more common in patients with hyperuricemia. So this will also be, with a knowledgeable patient, this can also be discussed. Now, the next question the patient can have is the high uric acid going to affect my diabetes status? Uric acid is a well-known initiator for tissue damage. It either both as a crystal dependent pathway, because by formation of crystals in the setting of hyperuricemia, it can lead to vessel damage. In addition, in a pathway independent of crystal, formation of crystal, by influencing the biochemical reactions, by increasing generation of superoxides and oxidative stress, it can cause endothelial damage and dysfunction. So studies have shown that uric acid, patients with increased uric acid in the setting of diabetes are at an increased risk for macrovascular disease, diabetic nephropathy, and even progression of diabetic nephropathy, diabetic retinopathy, diabetic neuropathy, and even possibly poor glycemic control. So yes, patient with the diabetes, with hyperuricemia in the setting of diabetes, we have to tell them that they do seem to be having a slightly increased risk for diabetic related complications in future. Again, at this point of time, we have to know the chicken and egg scenario, whether hyperuricemia and the diabetes and the poor control and the diabetic risk factors are an association, whether it coexists with the high sugars, or whether it's a causation, or whether it's an outcome of the complications of diabetes. We are still not very sure. The next question is my diet going to help in lowering uric acid? Yes. Diet forms a cornerstone of therapy in management of hyperuricemia, whether it is asymptomatic or symptomatic. Detrimental food materials such as animal proteins, red meat, seafood, shellfish, alcohol, sweetened soft drinks, sudden weight loss, vigorous exercise, dehydration are all found to increase the risk of, increase the chances of having high uric acid. Whereas coffee, cherries, vitamin C, gradual weight reduction, moderate exercise have been associated with improvement in the uric acid levels. What one has to remember is that although many of us do advise very rigorous withholding of vegetable proteins, studies have shown that the vegetable proteins are not really associated with hyperuricemia. It is only the animal proteins that we need to ask the patient to restrict. So the next question that we can expect is, are you, doctor, going to give me medications for hyperuricemia? So this is a very wonderful study that was published in the NEJM about a couple of months back. This is a very widely talked about study, the Pearl study. The background of this study was that previously some smaller studies had shown that usage of febuxostat and allopurinol were associated with reducing the risk of progression of diabetic nephropathy, as well as reducing the risk of proteinuria. In addition, animal studies had also shown that lowering uric acid with allopurinol or febuxostat was associated with reducing the complications of diabetes. So it was in this background that this very elaborate study was undertaken, and this was a very widely expected. The results of this study was actually widely coveted. And basically what they did in the study was that this was a randomized placebo-controlled study in patients with type 2 diabetes. Patients essentially had a uric acid of more than 4.5 milligram per deciliter, a GFR of between 40 to 99 milliliter per minute, and albuminuria of 20 to 3,333 microgram per minute. And what they did was that they gave these patients allopurinol or placebo for a period of around 2 years. And what they found was a period of 3 years. And what they found was that allopurinol was definitely, as expected, allopurinol was patients who received allopurinol had a much lesser serum urate levels as compared to patients who received placebo. However, when they looked at the progression of renal disease or the worsening of GSR, glomerular filtration rate, there was no significant difference between the patients who received placebo or allopurinol. So in these patients who had diabetes and mild kidney disease, usage of allopurinol was not associated with, over a period of 3 years, was not associated with any reduction in risk of progression of diabetic nephropathy. So this was a disappointment to many of us who were very eagerly looking for a positive outcome. And not only that, some of the secondary outcomes, such as urinary albumin excretion rate, what they found was that patients who use allopurinol had a higher urinary albumin excretion rate as compared to patients who use the placebo. And there were a slightly more increased risk of fatal or non-fatal cardiovascular event in patients who received allopurinol as against placebo. So at this point of time, at least in type 1 diabetes, in patients with type 1 diabetes and chronic kidney disease, the evidence is heavily against usage of allopurinol for just asymptomatic hyperuricemia. So the next question that we can expect is, are you going to give me medications? So in order to answer this question, are you going to give me medications? Based on whatever studies that we have discussed, there is no evidence at present that medications are going to help. Although they may lower uric acid, they are not likely to improve the complications related to diabetes. So how would we manage hyperuricemia in the setting of asymptomatic hyperuricemia? So you have an asymptomatic hyperuricemia, you can say that the uric acid level is, say, more than 6.8 or even 7. You can advise all these patients to go for the non-pharmacological therapy, the dietary restrictions as we discussed before, avoidance of red meat, shellfish, avoidance of alcohol, high fructose containing sugar syrups. Patient may be encouraged to take coffee. Moderate exercise and weight reduction may be advised. Rigorous exercise, on the other hand, is likely to cause hyperuricemia and hence may be avoided. And better to avoid any drugs which are likely to cause or worsen hyperuricemia. And if this uric acid levels is more than 9, because at least in a Japanese study had shown that high uric acid more than 9 has a very high risk of developing cardiovascular disease. And so if the uric acid level is more than 9, the patient may be initiated on urate lowering therapy, not just for the cardiovascular disease, but for preventing the increased risk of gout as well as other comorbidities as well. So if the patient is having a uric acid between 6.8 to 8.9, and if the patient is having a normal renal function, there is definitely no role for a urate lowering therapy. In the setting of uric acid between 6.8 to 8.9, in the setting of CKD 3 and 4, although the evidence from the Pearl study and subsequent couple of other studies were not in favor of giving allopurinol, most nephrologists prefer to give urate lowering therapy at this point of time, because there are some studies which have previously shown that urate lowering therapy might be beneficial in preventing the progression of CKD from stage 2, stage 3 and 4 to end-stage renal disease. And what is important is that we as doctors should know that there are some medicines which we may prefer in a patient with diabetes and hyperuricemia. There are some medicines which we would be using in patients with diabetes, which can positively influence the uric acid level. So if the patient is a hypertensive and angiotensin receptor blockade, especially losartan, has been found to lower the level of uric acid. Calcium channel blockers are also beneficial in lowering uric acid levels. When we are using oral hypoglycemic agents, preference may be given to metformins or the SGLT2 inhibitors, statins and fibrates when we are using a dyslipidemic therapy for dyslipidemia. High dose aspirin has been found to reduce uric acid, although low dose aspirin, that is less than 350 milligram per day, increases the dose of, increases the risk of hyperuricemia. So coming to the take-home messages, hyperuricemia is a fairly common complaint. It's mostly asymptomatic. And hyperuricemia is a marker for metabolic syndrome, cardiovascular diseases, hypertension. Whether hyperuricemia and metabolic syndrome, diabetes, hypertension, whether this is an association, whether because both of them coexist because of genetic, common genetic background, common metabolic background, we are not sure, or whether the hyperuricemia is causing the metabolic syndrome or the metabolic syndrome is causing the hyperuricemia. Still, this is a question which is a $1 million question basically. And we have to remember that drug treatment is not indicated for all patients with hyperuricemia. Dietary modification, however, can be advised for all patients with hyperuricemia, and the setting of hyperuricemia and other comorbidities, one can prefer drugs with urate lowering actions for the treatment of comorbidities. Thank you.